regarding neonatology. So we start this lecture with the so important issue regarding neonatology, and that is the respiratory tract disorders. In fact, respiratory disorders are the most frequent cause of admission for neonatal intensive care unit, of course, in both term and especially preterm infants. Generally, we can go rapidly about the signs and symptoms of respiratory distress that a neonate, term or a preterm may suffer from. Cyanosis, of course, cyanosis that we call about, and we can mean it, the central cyanosis, grunting due to the stiffness of the lung, flaring of the LNSI, chest obstruction, tachypneic, decreased breath sound, and even crepitation. Pallor, here consider one of the most important in severe respiratory distress regarding neonate. So this is the most common presentation of neonatology that may suffer from the respiratory problems. The first breath. Here we can say why the newborn takes first breath immediately after birth. We have many causes that make this unit take breathing that should be spontaneous and active immediately after complete birth. First cause, decline in auto pressure and pH and rise in pressure of CO2 as a result of course of interruption for the placental circulation. So any change in the biochemical value regarding respiratory system can help for initiation of the first breath. Besides reduction of the cardiac output and change in the body temperature, plus various tactile sensory inputs. So the environment of this neonate change. Sound of the nurse, sound of the other people help for initiation of the first breath beside others. So all of these help for initiation of the first breath. Keep in mind, one of the most problems that the neonates suffer from, and of course, preterm, that we call hyaline membrane disease or respiratory distress syndrome of the newborn. Respiratory distress syndrome of the newborn, and sometimes we call it respiratory distress syndrome of newborn type 1. Of course, this problem of preterm results from the biochemical immaturation of the lung of the newborn. So, biochemical maturation of the lung is so important. The most important perinatal event is the production of the surfactant by type 2 alveolar cell. Say, surfactant so important for the action of the lung after birth, and the presence of surfactant crucial for the optimum function of the lung. So the major function of the surfactant is to decrease the alveolar surface tension of the alveoli and so increases the lung compliance. Surfactant prevent alveolar collapse at the end of expiration and allow for opening of the alveoli at the lower intrathoracic pressure. So surfactant, so important to keep alveoli open during complete exhalation, and this is so important for proper aeration and oxygenation. The ratio of lecithin to sphingomyelin in the amniotic fluid is a reflection of the amount of the intrapulmonary surfactant. And the ratio of the lecithin to the sphingomyelin near 2 to 1 or greater usually indicate biochemical lung maturity. Of course, the release of the surfactant occurs at the 3rd trimester, and of course, maturated after 37-week gestation, when the neonate start to be term. So surfactant, so important. Immaturity of the lung, a cardinal feature of the preterm infants. Many conditions may help in increased production of the surfactant, like steroid administration, prolonged membrane rupture, preeclampsia, placental insufficiency, thyroid hormone, plus theophylline. In other side, we have other conditions that may decrease production of surfactant, maternal diabetes, and acute asphyxia. Keep in mind, not chronic asphyxia, acute asphyxia. Chronic asphyxia, especially in prolonged membrane rupture or placental insufficiency, may increase the surfactant production, while acute asphyxia, never. Pathophysiology. The lungs are poorly compliant owing to the deficiency of surfactant, resulting in a classic complex of progressive atelectasis, intrapulmonary shunting, hypoxemia, and finally cyanosis. So the hyaline membrane that forms and lines the alveoli is composed of protein and soft epithelium. So this, as a result of oxygen exposure, alveolar capillary leakage, and forces generated by mechanical ventilation. So all of these may help in formation of the hyaline membrane that, of course, result in different problem to the preterm infant. Clinical features. As we mentioned in the beginning of the lecture, about some important clinical features of the respiratory problem in the neonate. So these affected premature infants may suffer from tachypnea, grunting, nasal flaring, chest obstruction, and cyanosis. Of course, the problem of the respiratory distress syndrome of the neonate present in the first few hours of life. On auscultation, we have a decreased air entry and apnea and irregular respiration, of course, considered ominous sign that put the neonate in a critical zone that need immediate action. Respiratory failure may occur in severe course. So the clinical feature, of course, graduated according to the maturity and according to the amount of the surfactant that released according to the gestational age. clinical course. The natural course is a progressive worsening over the first 48 to 72 hours of life. After the initial insult to the airway, the epithelium is repopulated with type 2 alveolar cells that start to release the surfactant. So subsequently, there is an increase in the production and release of surfactant, so that there are sufficient quantities in the airspace after 72 hours of life. Of course, this results in improvement of the clinical feature by improving in the lung compliance. So, in summary, clinical features of the respiratory distress syndrome type 1 regarding the unit mostly are the first 3 days of life, then start to be improved due to the production of the surfactant. So during these few days, you should help the neonate according to the severity of the clinical features. This is a picture of neonate with respiratory distress syndrome, of course, severe type. In this X-ray, we can see air bronchogram as the 3 arrows shown that, plus what we call ground glass appearance of the both lung, of course, uniform, involve both lung field. This is another example, but here we have a complicated by pneumothorax of the left side of the lung. So we have a compressed the lung with the clear cut of pneumothorax. Therapy and prognosis. Conventional therapy for the affected premature infant include supportive as well as the administration of oxygen. It's also necessary to increase the mean airway pressure by use of a continuous positive airway pressure, CPAP, or intermittent assisted ventilation, or a high frequency oscillation. Of course, outcome with conventional therapy is good. So this is a supportive measure. To deal with the essential cause of this problem, we can start with exogenous surfactant. Surfactant has become an important intervention for those infants with severe deficiency. Alveolar opening and improvement in the oxygenation of VTH occur almost immediately. Of course, surfactant given through the intubation of the neonate laryngoscope and insert a tube, and then we release the surfactant to the bronchial tree. Of course, that immediately improves. Of course, surfactant so important for the lung maturation, but exogenous surfactant replacement, of course, not free of complications. many complications, and the most important that can cause pulmonary hemorrhage. So keep this possibility in your mind. Complications that associated with respiratory distress syndrome type 1, pneumothorax, patent ductus arteriosus, intraventricular hemorrhage, necrotizing enterocolitis, bronchopulmonary dysplasia, retinopathy of prematurity. Of course, if you need more detail, you can return to your textbook to read about each of these important complications of the respiratory distress syndrome. Prevention. When amniotic fluid assessment reveals a fetal lung immaturity and preterm cannot be prevented, of course, you can assess this by study of the lecithin to sphingomyelin ratio after aspirate of the amniotic fluid. And if the pregnancy cannot be prevented, you can administer corticosteroid to the mother before 48 hours. That, of course, help to induct the lung surfactant maturation. So it's well known that to add corticosteroid like dexamethasone to the pregnant mother before labor. Of course, you need at least 2 days for action of the steroid. Any question, please? Okay. As I mentioned, we can call the respiratory distress syndrome of the premature type 1. We have other special entity that called transient tachypnea of the newborn. Transient tachypnea of a newborn, we can name it in another name, respiratory distress syndrome of the neonate type 2. If you return to the textbook, you can find such classification and you can read more. Transient tachypnea of newborn, abbreviated as TTN, thought to result from the decreased lymphatic absorption of the fetal lung fluid. It's almost commonly occur in the infant born near term. So TTN, a disease of preterm and near term in comparison to the type 1 of respiratory distress syndrome, exclusively of the preterm infant. So near term, they are delivered by cesarean section without preceding labor. Both of them help a such problem because the infant not pass through the birth canal and not exposed to the squeeze of the birth canal that help to get out the fluid and secretion inside the lung passage. So after a while, lymphatic drainage can help in reduction of this problem and improvement later on. So here the pathology is presence of the lung fluid and the surfactant production, of course, within optimum level if we compare with the type 1. Clinical features: tachypnea is a quiet or mild and usually not associated with retraction. The infant appear comfortable and rarely cyanosed. So here, you should make a simple comparison with the type 1 based on these facts. Diagnosis, of course, diagnose on the event or delivery, chest radiograph that characterized by the fluid in the major fissures, prominent vascular marking, increased interstitial marking, and hyperinflation. Here, if we compare the X-ray finding in type 1 and type 2, type 1 surfactant deficiency, the X-ray in severe case give us granulous appearance with air pronogram, while in type 2 TTN, the finding of X-ray so mild, presence of fluid or permanent vascular marking. Therapy is supportive, tachypnea resolved in a few days. Low dose of supplemental oxygen may be required. While in type 1, of course, intensive care plus supplementation by surfactant. So, as we say, you can make a simple comparison between these two important conditions. Any question, please?
Inshallah, معك دكتور.
Inshallah. Okay. If you want to repeat some information, if you want. So, after we finishing, the most important part is respiratory distress. We can talk about important another condition that relate to the lung of the newborn, persistent fetal circulation or persistent pulmonary hypertension. The same meaning, usually a disease of term. Infants who are experiencing acute or chronic in utero asphyxia. See frequently infant with meconium aspiration syndrome. Pathophysiology. The primary abnormality is a failure of the pulmonary vascular resistance to fall with postnatal lung expansion and oxygenation. Here, as you know, normally at birth, the systemic vascular resistance arises as a result of the cessation of blood flow through the placenta, and the pulmonary vascular resistance fall with the first breath after complete delivery. This is a fact. In utero, you know, the right side, of course, of the heart characterized by a high resistance and of course higher than the left. After birth, the reverse should be true. The pulmonary vascular resistance start to be decreased and the systemic vascular resistance start to be increased and of course continue for life. While here, this action never happened. So, with the persistence of the fetal circulation, that we mean the pulmonary vascular resistance still high, the pulmonary vascular resistance continue to be high and may in fact be higher than systemic resistance. This resulting in shunting of the oxygen blood, which is returned to the right side of the heart away from the lung. As you know, the return blood or the venous blood comes to the right side of the heart that should be pumped to the lung. Here we have a high resistant pulmonary resistance. So the blood will be shunted to the left side before passing to the lung. So this blood, of course, deoxygenated, shunted to the left side of the heart, then to be pumped to the remnant of the body through the left heart. This pumping of containing deoxygenated blood. Of course, the shunting, we have two ways, maybe through the foramen of ovary or through the patent ductus arteriosus. So the net result, shifting of the deoxygenated blood to the remnant of the body by the left heart. So the net result, the whole body, of course, deoxygenated blood is the more prominent one. How we know the clinical features of this newborn? The infant have a rapidly progressive cyanosis associated with mild to severe respiratory distress. There is a varied response to oxygen administration depending on the size of the shunt. Here, the response less to oxygen in comparison to other lung problems. Diagnosis. Diagnosis suggested by a history of perinatal asphyxia and clinical cyanosis at birth, accompanied with a negative cardiovascular examination and negative chest radiograph. Although the mesenchymal disease may be coexist, like RDS or meconium aspiration syndrome. Here, the trick for this issue of respiratory distress is we have a full term and we have clear lung examination and we have a clear cardiac examination. With a full term, you should think about this possibility. Clear chest, normal cardiac examination, full term, meconium aspirate syndrome. Of course, all of these help us to think about this possibility. Echocardiograph, so helpful to establish the diagnosis and should demonstrate the following: absence of cyanotic heart disease, increased pulmonary vascular resistance, the presence of right to left shunt at the foramen of ovary or ductus arteriosus, or even both. So, this important issue, after exclusion of the lung and cardiac problem, you can think about this. Therapy, oxygen, mechanical ventilation, hyperventilation, support of the systemic blood pressure by administration of sodium bicarbonate, and pulmonary vasodilators. The overall mortality rate associated with this disease is a high. Extracorporeal membrane oxygenation, ECMO, may improve the outcome. So the prognosis here, compared with the RDS, compared with the TTN, to note the difference in the prognosis, compare the causes, compare the clinical features, and compare the echo finding, and compare by therapy. So make a short comparison that help to be more familiar with such important issue. Any question, please?
إن شاء الله معك دكتور.
Okay. Important. Another issue, apnea. Of course, in your theory or in your practice, you can hear a lot of apnea, and you hear it more frequently. Apnea, what we mean by apnea, is a cessation of breathing for a longer than 20 seconds. Of course, apnea affect premature more than mature. That we call apnea of prematurity. Of course, reflect immaturity of the respiratory control mechanism in the brain stem. So apnea more with preterm. Of course, during your lectures, you can make a simple classification of the disease that affect term and the disease that affect preterm to be more easier to understand the neonate. Clinical features of apnea, bradycardia, often associated with apnea. Bradycardia, so essential for diagnosis of apnea because we have another simple or transient apnea or even periodic breathing of the term or preterm that not associated with the bradycardia. So this is not real apnea. Apnea should be associated with bradycardia. Apnea of prematurity is characterized by periodic breathing and intermittent hypoxia, which further diminish respiratory drive. So simple apnea not affect the heart rate, while real apnea affect the heart rate. Diagnosis. Apnea of prematurity is made after exclusion other reason for the apnea. So before to say this is apnea of prematurity, you can exclude other causes of apnea that may be serious, like respiratory problems, pneumonia, airway obstruction, hypoxia, pneumothorax, central nervous system, tracheal hemorrhage, seizure, drugs or hypoxic injury, function like sepsis or meningitis, even metabolic, hypoglycemia, hypocalcemia, decrease or increase in sodium, hypothermia, cardiovascular problem, heart failure, hypertension, or even gastrointestinal problem like necrotic enterocolitis. All of these should be excluded after say this is apnea of prematurity. Therapy. All the time you should observe the preterm. All the time you should observe the preterm that admit to the intensive care unit. So you can start with tactile stimulation, maintain body temperature, add oxygen if need, administration of respiratory stimulant, theophylline or caffeine. This is so important in recurrent apnea, of course. Use a conscious positive airway or intermittent assisted ventilation, and beside treatment of the possible cause. So simple to be treated, but need a well-trained staff for observe as such important issue. Prognosis. Apnea of prematurity does not alter prognosis unless it's severe and may be refractory to the treatment. Most of the newborn pass this problem and grow normally. Another problems important that may happen immediately after birth, choanal atresia. Choanal atresia, of course, problem that affect the nose. It may be unilateral or bilateral obstruction of the posterior nasal airway, of course, by a membrane or even septa that formed from bone. This is a life-threatening anomaly resulting from the failure of the bucconasal mucosa to be ruptured. Of course, it's life-threatening in case of bilateral. Clinical features of this congenital abnormalities. As you know, the newborn are obligated by nose breathing. So if we have a bilateral problem, this resulting immediately after birth as an airway obstruction, apnea and cyanosis. Of course, the newborn in severe distress. This distress and cyanosis is relieved by cry. Why? Because during cry, the newborn starts to breathe through the mouth. But after a quietness, the distress and cyanosis return again, that improve again by cry. So this event help to think about this abnormality. Quietness make the child or the newborn in distress, while he cry, help him to be more pink. Unilateral, of course, may be asymptomatic, can be discovered by inability to pass a oropharynx or by radiograph using a suction catheter through the nostril. Of course, in bilateral or even unilateral, we have a difficulty to pass a catheter through the nose. We can use a catheter and radiograph to show the area of nasal obstruction. So important to use a gentle passage of the suction catheter to the both nostril to discover this possibility. Therapy, if we have a case of choanal atresia, of course, we have an emergency case. We should insert or ensure the airway by using of the oral airway or even by endotracheal tubation. Of course, the definite therapy is a surgical reconstruction. This is, of course, for bilateral choanal atresia, considered as a true emergency. Of course, it's shared between the pediatrician and the ENT specialist. We have another important issue regarding the respiratory problems. Diaphragmatic hernia. Simply diaphragmatic hernia, it means displacement of the abdominal content to the thoracic cavity through the defect in the diaphragm. As you know, the diaphragm is the important respiratory muscle that's separated from the chest, from the abdomen. Here in the diaphragmatic hernia, we have a defect in this diaphragm and herniation of the abdominal cavity to the chest. We have two types of the diaphragmatic defect: hernia through the foramen of Bogdanic, are by far the most common seen in diaphragmatic hernia, according to the most common type. The defect all the time on the left occur in the posterior lateral portion of the diaphragm, result from the failure of the peritoneal canal to close, which normally occur between 6 to 8 weeks of gestation. So we have a defect on the left side of the diaphragm. So here, the gastric content pushed or herniated to the left side of the chest. In comparison to another diaphragmatic defect through the foramen of Morgagni, are sometimes rare, and hernia usually occur on the right side. Frequently, the hernia contain or just an omentum of the abdomen, and the newborn, of course, most of cases asymptomatic, because a herniation can occur within a limit, while the left side, of course, the more severe one. Pathophysiology. So ipsilateral pulmonary hypoplasia results from the compression of the affected lung by displaced gastrointestinal organs. So the lung on the same side will be shrinked or hypoplastic in nature. Not only this, we may have a shifting of the mediastinum and result in a compression of the another lung. Of course, the other lung may be suffer from the hypoplastic changes, but of course for a lesser degree in comparison to the left one. Diagnosis is confirmed by chest radiograph demonstrating air fluid bowel in the hemothorax. This is a picture of diaphragmatic hernia of the gastric content to the left chest. Of course, you can see a lot of gastric content that make pressure and shifting of the mediastinum to another side. Clinical features of this, of course, severe respiratory distress, of course, after birth, depend on the severity of the hypoplasia of the lung, of course, and you can note a scaphoid abdomen of the newborn. Scaphoid abdomen because the gastric content shifted to the lung, and we can hear the bowel sound and decrease the aeration on the affected side of the chest. Here, you can intubate, vigorous oxygenation plus mechanical ventilation. So the compress of the intestinal tract with the nasogastric tube. So important to insert nasogastric tube to compress the lung tissue, to compress the gastric content to make less pressure on the lung, plus correction of the metabolic acidosis. And finally, after stabilized, the newborn, we can send for correct of course, permanent correct of the defect. Keep in mind, mask and back ventilation should be avoided or minimized because it results in more distension of the bowel and further compression of the pulmonary tissues. So usual mask should be avoided generally to minimize this pressure we mentioned. Other problems should be corrected, like pulmonary hypertension. We can use extracorporeal membrane oxygenation in selected infants. So, therapy, first start with decompress of the intestinal tract, give oxygen through the intubation, not a mask, and then we can correct other problem one by one till surgical correction. So important to keep the diaphragmatic hernia in differential diagnosis of any form that suffer from severe respiratory distress. So important and so easy to be treated if discovered early. Prognosis, survival rate depends on the degree of the lung hypoplasia, presence or absence of other abnormalities, symptoms that appear before 24 hours of age, herniation to the contralateral lung, or need for ECMO. With conventional therapy, survival rate are about 70%, and usage of extracorporeal membrane help improve the survival. So, early detection, early intervention help to increase the percentage of survival. Important, and of course, we face a lot of problem if we diagnose as such defect. Keep in mind, we can talk about the last issue in this lecture about the meconium aspiration syndrome, abbreviated as a MAS, is a multi-organ disorder with perinatal stress as the underlying cause. It's most commonly occurred in the post and term infant and who are small for gestational age due to the intrauterine growth retardation. Both have placental insufficiency as a common cause for fetal hypoxia. Pathophysiology. Of course, a meconium gastric content that collected during the period of pregnancy through the continuous shedding of the intestinal cell that collected and then became a meconium. And meconium, of course, as you know, should be kept inside the GIT and never pass before labor, not like urination. Pathophysiology of this problem, the fetal hypoxia triggers a vagal reflex. So this results in passage of thick meconium to the amniotic fluid. And as you know, the amniotic fluid should be kept clear and sterile. In this abnormality and passage of meconium make this amniotic fluid not clear or sterile. So the contaminated amniotic fluid is swallowed into the oropharynx and aspirated at birth with the initiation of the breathing. So keep in mind the problem starts at time of initiation of breathing. With severe fetal asphyxia and acidosis, of course, followed, the meconium may be aspirated perinatally because of the fetal gasping. Other organ affected, of course, not only the lung, brain, heart, GIT, and even kidneys. But the primary organ that suffer more is the lung. The anal sphincter or the fetal should be kept tight all the time. But when the fetus exposed to unfavorable conditions with acidosis that make this anal sphincter to be relaxed and passage of the meconium to the amniotic fluid. As we say, this is a disease of mature or post-mature infant, and meconium aspirate syndrome never to be happen to the premature, because the premature anal sphincter less to be respond to the hypoxia, so not relaxed easily. So it is a disease of post-mature and can, of course, happen in mature if exposed to the unfavorable conditions. Diagnosis: established by presence of meconium in the trachea or amniotic fluid, accompanied by respiratory distress. Chest radiograph help to show the different degrees of infiltration and hyperventilation. But the most important is the presence of meconium by the amniotic fluid or sting of the umbilical cord, or even the nail. Therapy: because most episodes of aspiration occur in the initiation of the respiration, the most effective therapy is to prevention. This consists of removal of the meconium before the initiation of the ventilation, so the meconium is removed from the infant airway by this phloem. So just when they head out, you start to clean the mouth from the meconium. So the oropharynx is suctioned before both delivery of the thorax and initiation of breathing, and again when the infant on the warmer bed. So your suction starts when the head just out before taking first breath, because when he starts to breathe, he may aspirate a lot of meconium, and the problem of course continue for a long time. The vocal cords are visualized using a laryngoscope and large trachea tube or DD suction used for such problem. Of course, the procedure of suctioning repeated again and again till we clean the trachea from the meconium. If aspiration happen, of course, the newborn start grunting with sign of respiratory distress. At that time, oxygen plus mechanical ventilation may be needed. Persistent pulmonary hypertension, as we talked before, may be important residual effect of a meconium aspiration syndrome. Keep in mind, these are more serious and can be prevented easily by immediate suctioning of the oropharynx, immediately after appearance of the head, and before initiation of the first breath. So important to keep this possibility in your mind. Of course, we can stop at this point, and we can complete in the next lecture. Any question, please?